We asked what kind of content you would like, and you answered. So there are two reasons why I am so excited about the following piece of content. So the first is that it actually came from members inside the Pediatric Network. So we put up a poll and we asked you, what kind of content would you like to see here on the network? So number one was pediatric examination, and I promise you that is in the works as we speak. But number two wasn't even something that we at the Pediatric Network put in the poll. It was something put up by a member, and it was a question. And the question was, why are we seeing so much more hypermobility and low tone in kids these days? So I decided that to answer that kind of question, I needed to go to the source, which is the second reason I'm so excited about this piece of content. Because it gave me an excuse to speak to someone I have been trying to speak to and looking for an excuse to speak to for a long time. So I got to get onto Zoom with Dr. Elisabeth Davidson, who is a chiropractor who is in Scotland in a little town called Inverurie, which is just outside Aberdeen. And if you want to know anything about hypermobility, she is your doc. So without further ado, here is us at the Pediatric Network answering that question with our experts as to why am I seeing so much more hypermobility and low tone in children. Hello and welcome to the Pediatric Network. My name is Mike Marinas. I'm your chiropractor and host here for everything pediatrics. So you asked on one of the polls that we put up on the Facebook page, what kind of content can we bring you? And one of the things that actually came up second, and I have a good idea who put it up there because it's a mate of mine from Amsterdam who has a good feeling for these kind of things and is very interested in hypermobility. The question that I didn't even put up, which is why polls are so good, that we put up that said, let's talk about hypermobility in children. Let's talk about it in infants. And when I heard about that, I said to myself, right, there's one person in the world I know who to speak to, and that is Elisabeth Davidson, Doctor of Chiropractic. How are you doing?
I'm very well. Thank you, Mike. Nice to see you.
Yeah, it's wonderful to have you on here. We've obviously been chatting over all sorts of technology, but this is actually the first time we get to chat to each other face to face. I'm really happy to have this. Yeah, it's going to be lovely.
Thank you.
So let me do a nice intro for you. So Dr. Elisabeth Davidson, 26 years in practice, graduate from AECC in the UK in '94, then proceeded to do her master's degree in pediatrics from 2004 to 2007. She's a fellow of the Royal College of Chiropractors Pediatric Society, and she's director of academic affairs there as well. So we really do have the right person for the job on with us today. Also working on a lot of competencies and has been in this teaching role for about 11 years now. So I don't think we could actually have anyone better to guide us through hypermobility in infants and children than we could with Dr. Elisabeth. So thank you, first of all, so much for your time.
Thank you very much, Mike. And not to mention that I also have hypermobility myself. So this is a subject that's very close to my heart.
There we go. We would just say now that you were diagnosed with it six years ago?
Yes, that's correct, yeah.
Okay. And then obviously having something very personal like that would then open you up to going, well, let's learn as much as we can and let's get as much info as we can.
Yeah, I mean, it really opened my eyes to a whole subgroup of patients, both adults and children, that I realized I was failing because I hadn't actually recognized what was wrong with them. And they are often misdiagnosed with various sort of nefarious labels like chronic fatigue syndrome or even Munchausen syndrome, or, you know, often doctors just don't believe that there's something actually wrong with them. And that was kind of my experience. I mean, I went back and forth to the doctors for 20 years before I finally got a proper diagnosis. And so I decided to put all my knowledge together. There was a lot of research that came out during that time, and I've now been teaching a seminar for the Royal College for the last couple of years, and mainly in the UK, but also in Europe, about hypermobility and how we recognize and manage these patients.
Okay, and that I think sounds like something that we could really nicely put onto an online format for some of the people that can't get to those areas. So I think we might look at that as something.
Yeah, that would be great.
I think it would be good. So now we want to talk about, the question was, why is there such an increase or perceived increase at the moment in hypermobility in kids and infants? But I think before we tackle that, I think for a lot of people, because I know we have a lot of students on and we have a lot of people from different disciplines, so maybe we should first tackle, what is hypermobility? What are we speaking about when we talk about this term?
Yes, it's actually a genetic condition, but it's multifactorial because there's a lot of environmental and nutritional influences in how that disease can express itself in different people. And it's also on a spectrum. So you can be a little bit hypermobile, or you can be a contortionist. You can be not really affected by it very much, or you could be almost in a wheelchair. It's also, it tends to progress as you get older. So you may only have either nothing or a few little symptoms in childhood, and then as you get older, it gets worse and worse. But it's basically, hypermobility in itself is defined as an ability to actively or passively perform joint range of motions which exceed the norm. So your joints, for instance, your elbow can extend beyond 180 degrees. You can put your hands flat on the floor with your knees straight. You can bend your thumb down towards and touch your forearm. Yeah, I can't do this anymore because I'm getting older now. I'm getting stiff, but you can extend your little finger beyond 90 degrees. So there's a scale called the Bacon scale that we, excuse me, that we use to grade it. But that's not everything. That's only a small part of it nowadays. That we recognize this huge component in terms of a lot of children have gastrointestinal issues with it. It can affect your eyes, your ears, your hearing, your vision, your smell. It can affect your skin. A lot of people with high mobility have extremely soft, sort of velvety skin. So there's a whole range of stuff now that has been recognized as being part of the criteria, and that changed in 2017 when a new criteria was published. So I mean, I noticed you talked about type 3 earlier. We don't actually call it that anymore. So that's an obsolete term, but we can go through this. So one of the most well-known parts of hypermobility is probably Ehlers-Danlos syndrome, but you've also got things like Marfan's or osteogenesis imperfecta. You've got Fragile X syndrome, Klinefelter syndrome, and a range of other, even Down syndrome, and a sort of more rare one called Loeys-Dietz syndrome. They all have hypermobility as part of their clinical picture.
Okay, so that's our first thing to be able to firm up here, is that hypermobility is kind of a generic term that's going to sit up at the top, and it's going to feature in a whole lot of different diagnoses. And
Absolutely.
I think the second thing, so important that you said there, you're not hypermobile or not.
No.
It's a scale, and that scale changes with age as well.
Yes, very much so. I mean, I could put my feet behind my neck when I was a kid, and I could do the splits well into my 30s probably, but in my 50s now, I'm definitely more flexible than most people, but for me, I'm a lot stiffer than I used to be. So that's not uncommon that you see that sort of regression and flexibility as you get older.
Okay, so something to look at when you're looking at your older patients as well, to go, well, you know, it might have been an to question that with your history, to kind of look back and go, when you were a kid, were these the things that were happening?
That's absolutely correct, Mike. We now have to say, not just can you do it now, but could you ever do it is a big part of the questioning when you're looking at the picture.
Okay. The other thing that you talked about that really sparked something with me is because it's connective tissue, you have connective tissue everywhere, and that's going to be involved in a whole lot of different senses. So it's not just going, can you do this? Can you do that? But now it's to go, I'm guessing, I mean, the extraocular muscles are going to be involved in this, and muscles.
That's right, yeah. Yeah, absolutely. And one of the biggest things that tends to be involved is actually the gastrointestinal system, but also veins, and the heart itself, of course, has a lot of connective tissues in it. So for me, for instance, one of the things I found out was that I have a slightly strange ECG, which always gets doctors very excited, but I've learned now that that's actually part of the fact that you've got odd connective tissue. So it throws up a slightly different picture. And now that I know what it is, it doesn't matter so much, but it's good to know.
Wow, yeah, good to know for yourself, and then good to be able to interpret other people's
Absolutely.
Yeah.
We're going to talk a little bit more about the GI part of it. But I think in babies, the most important thing is probably that it's what we see as low muscle tone, more than the hypermobility, because really all children are per definition hypermobile when they're young because their joints aren't fully formed. So you can't really, traditionally, you can't really diagnose it until they're about 3 or 4 years of age. But and also the Baton scale has been shown in the literature to not really be particularly accurate for under 5 years old. So they're now looking at coming up with a different scale for younger children. But what I've noticed in my practice is they almost always have a combination of hypermobility and global low muscle tone.
Okay, because I mean that brings us right on to, because the most important is how do we find it as clinicians, or what are we looking for in the infant population to be able to go, this is something I need to watch.
Absolutely. I think that what also is important to remember is that it tends to run in families. It is genetic. So very often, if you know that mom is hypermobile, or that it tends to affect women worse than men, although genetically it tends to be the same sort of prevalence. But women are affected by it by a factor of 7 more than men are because of hormones. So of course, if a woman has had a difficult pregnancy, or even a very, very, very easy birth, or you know that she's got hypermobility, then you would really want to have a look at that baby in detail to see whether they have potentially an issue, because very often the first thing that will be noticed is they have delayed development. So they often don't roll, they don't crawl, they don't sit, they don't stand as early as other children. And once they do, they're often very clumsy and they fall all the time. They tend to have quite a wide stance, wide gait, because they're so unstable. And there's particular muscle groups that tends to be affected, which is more the hip muscles, so your glutes, your gluteus medius, your gluteus maximus, your hamstrings are often quite tight. And often where it's easiest to see is in children is that they get very, very tense all the way around their ankles, because their ankles are unstable. So they have to use the calf muscles extra. And they'll often, when they're old enough, complain about growing pains as one of the first things, because children don't know that it's different.
Okay, that is fascinating. Yeah, because of course, with the having that hypermobility, it's going to be that muscular pull that's going to have to try and hold them together. I always
Absolutely.
think that there's a gymnast friend of mine who was she's actually on the group here. She performed and competed for South Africa when she was about 13 or so, and the flexibility she had was crazy. But obviously at that time, not to say she was hypermobile, but at that time the amount of muscle tension she had to be able to hold that together was fantastic. In later years, the pain starts to come up because now you have this mobility which has been produced over so much time, but now the muscle's not there to be able to hold you, and now joints start to inflame and you start to get this pain that comes up.
Absolutely. I mean, a lot of children with hypermobility tend to gravitate towards sports like gymnastics or ballet or diving. I did myself. I was really flexible, so it was easy to do a lot of things. But unfortunately, those are also high impact type exercise that can cause injury easily, or long-term not long-term consequences. So you've got to be a little bit careful about. I had a young lad who was 16 who was clearly hypermobile, and he loved playing rugby. And I had to sort of say to him that was possibly one of the worst sports that he could do, which he was absolutely devastated. But what can you do?
Yeah, but you're saving him from a lifetime of pain once that rugby is over. So
exactly.
Job done. So our question on the poll was, is hypermobility and low tone increasing in our population? Is it increasing? Are we seeing more of it now than we used to see?
It's actually a question that's really difficult to answer. I turned to a couple of the experts in the UK, actually, when you asked me that question. And it's impossible to know for sure, because the diagnosed prevalence has definitely increased, but has the actual prevalence increased? That's the question. Are we just better at diagnosing it now? Which potentially, I think that's the question. 20 years ago, it was thought that it was maybe 1 in 500, but now we know it's as much as 1 to 3% that have the genetic hypermobility potential. That doesn't necessarily mean that 1 to 3% will become ill with it. But pre sort of 2017, we really only looked at the hypermobility and the musculoskeletal aspect of it. But now, since the new criteria was diagnosed in 2017, it's probably, if anything, harder to become diagnosed, but they've actually realized that the prevalence is much higher than they thought. And I was speaking to Dr. Emma Reinhold, she's a GP and a researcher in the UK, and she's authored several papers on Ehlers-Danlos syndrome, and she's also created a GP toolkit, which I'll talk about more when we do the seminar, which is fantastic toolkit to help you diagnose your patients and get them further on into the system to get help. And she says basically that we don't know. It's potentially, it has increased, or it could be that we're just better at recognizing it. But there's also some experts who have suggested that the severity of the symptoms have increased in the last sort of 10, 15 years. And some of them are hypothesizing that this could either be environmental factors or nutritional factors, and then that's making people express it worse. They might have, we don't know that the genetic prevalence has increased, but it seems to be affecting people in a way that's much worse.
Okay, so not just the fact that you are genetically primed for hypermobility, but then kind of a nature nurture story, then it has to do with what kind of nutrition you're getting in, what the environment is giving you, and to those two, what's happening. Can we speak then on nutrition? What would have an effect?
Well, first of all, this is where we have to come back to the gastrointestinal aspect of it. Part of the problem is if you don't have enough collagen in your GI tract, then you actually are more prone to have malabsorption. So even in very young children, you can have a reduction in absorption of vitamins, for instance, like vitamin D, vitamin C, and your more important ones, manganese and magnesium, zinc, iron. So it's very common for them to be either anemic or even have, if not osteomalacia, then at least be low in vitamin D, which is sort of common anyway in the modern world. So those are things that, I don't know about you in South Africa, but in the UK, people think they have a really good diet. But then when you actually question them, well, what does your child eat? You think, well, that's, in my book, not good. And they are definitely not getting the correct nutrients. And that's something I'm currently looking into quite a bit. So it's an aspect we need to look at in children to ensure that they get enough of the correct nutrients.
Yeah, definitely. I definitely find it over here. I mean, one of the things as well with South Africa, because everyone thinks that they're running around in the sun, they think their vitamin D is fine, which generally, it is pretty good because we are out, but there are those winter months where you are more inside your house, and vitamin D has to become more part of your intake than it would have been. And also you get into that thing where it becomes, yes, the diet's fine, and then you find out that the mom and dad are eating these wonderful foods, but the children will only eat fish fingers, and they won't eat peas, and they won't eat this, and you won't eat that. And sometimes it's one of those things where you talk it through with them that they start to go, oh, heck, maybe this is something, maybe the diet's not what it should be.
Yeah, absolutely. And often you'll find that IBS will run in the family and gut problems will run in the family anyway. So the parents will maybe be eating a restricted diet and the children even more so, because IBS and food allergies is very common when you have hypermobility. This is something that can be even seen early on. I don't know about you, but we're seeing so many children nowadays that have dairy allergies or dairy intolerance, which seems to have increased phenomenally in the last 10, 15 years. But the main problem you often see in children with hypermobility is they often have gluten allergy. So you will see IBS because of that. Okay. And they may also develop a sort of histamine intolerance, which can eventually develop into sort of mast cell activation disorder. So they start getting more and more allergic to different foods that if it's not recognized and treated early on, it can become quite limiting.
That is fascinating. I concur with you 100%. The cow's milk protein allergy here is, I think with us, as the reflux diagnosis has increased, that has increased as well. And it's become that everybody is now cow's milk intolerant. And now you don't even need the other signs. You don't even need the skin rashes. You don't need the blood stools, none of that. It's all just like, no, this is what it is. And because of that, let's take you off breastfeeding straight away.
Yeah, which is the worst thing you can do, but that's a whole nother story, isn't it?
Other thing. Okay, so when we talk about intervention, because what would we then do? And let's talk, I suppose, more to the littlies, but what is the intervention to mobility?
In children, you're really looking at prevention more than anything else. So it's about recognizing it, ensuring that they don't go and do sports like rugby or karate or boxing or something that's high impact, because the potential for injury is quite high in those sports. But they do need to be active, and they do need to try and maintain a certain level of fitness. It's also about educating them about the condition and understanding and I suppose accepting your own limitations, because they're not going to be able to do what some of their peers can do. I have developed sort of several physical therapy type programs that I use for different age groups. So you have to make sure that you can't just give them your normal exercises that you would give to all the children, because they don't have the strength. They don't have the same proprioceptive feedback. They don't have a sense of where their joints are in space, so they will often end up going into extreme postures, which can then either damage them or can affect their long-term proprioception. So proprioceptive rehab is one of the things I often do. We do a little bit of TheraBand strengthening, but it has to be minimal compared to what normal children can do. But all the research shows that early intervention and exercise is really the key to help preventing long-term issues. If they are very, very flexible and very hypermobile, then you can get various aids. You can get finger rings, you can get splints for various joints, to help them walk. There's a whole range of sort of particular exercises that are appropriate for that age group. So it's about really trying, as I say, to prevent long-term injuries, because once you have injuries, we know that changes the chemistry in the body, and then the body just starts to react in a different way. So what often happens is the first sort of 10 years of life, they tend to be clumsy, maybe have global motor delays, they may have the odd injury, but nothing major. But then by the time they're in their teens, they will start getting fatigue, malaise, they might start to develop the gut issues, the polyarticular pain, and they'll also often develop dysautonomia. So they may have POTS, postural orthostatic tachycardia syndrome, or strange and weird and wonderful peripheral paresthesias that doesn't seem to follow a normal pattern. And then usually by the time they're in their 20s, 30s, or 40s, depending on how fit they are to start with, that's when you start getting the early joint complications. So your arthritis, your recurrent sprains and strains, which eventually gets to the point where you just can't get back to a level of fitness. So if we can come back to, in their first decade and start teaching them how to look after themselves, and then hopefully we can prevent long-term consequences of it.
Yeah,
and I think, pain avoidance behavior is another big issue that I see, and I've noticed it in myself. Obviously, if something hurts, you don't want to do it, so you have to teach them about what is good pain and what is pain that's acceptable, and when is pain not good.
No, absolutely right. And that goes exactly to what I was just thinking now, is it's all about, as a clinician, guiding their life choices, being able to say, look, you have this, as this is kind of this is what you now have. As someone else who is an office worker that has to sit in that chair for 8-9 hours a day, this is your thing. And these are the good choices and these are the bad choices. And the more you do the bad choices, the more there's going to be trouble along the way. And here are the ways to be able to mitigate that.
That's right. Well, one thing we have to bear in mind is that it is absolutely contraindicated to use high velocity, low form of low HVLA type adjustment on anyone who has hypermobility. It's in the WHO guidelines that we should not be using it. That doesn't mean to say that you can't work with them. You can do low force techniques. You can use soft tissue work. There's lots of alternatives, but we just need to bear that in mind, that that's contraindicated in hypermobility.
Fantastic. I really like that. Yeah. Because obviously you don't want to cause any damage to that, but having said that, still mobility in those low force.
Yeah, it's important to strengthen the weak muscles and toning down the ones that are hyperactive. So stretching is absolutely important to do, but they just need to make sure that they're stretching the correct muscles and that they don't go beyond their normal sort of joint range.
Okay. And yeah, I'm looking very forward to you putting a course together on that, because that will be fantastic to be able to learn exactly what and how do we best manage these cases. Before we sign off, could I ask, a little selfishly, I suppose, just because I work with the littlies a lot, in terms of the low tone babies that we're seeing, what kind of interventions are we looking at for them? What are we telling parents to watch out for?
Yeah, I try and involve the parents in their treatment because I think it works better if it's done on a daily basis. And the parents really need to understand that this is not a quick fix. You know, there's no magic cure for this, and they need to be involved in this treatment of their child. And so I give them, for the young babies, I get the parents to hold their trunk and then just gently sort of rock them from side to side so that you're stimulating not only the spinal muscles, but also the inner ear and the proprioception. You can maybe sit and bounce them on a ball, well supported. You can give them exercises to help them strengthen up. It's very, very important for them to have tummy time, which is something parents are often resistant in doing. Oh, they don't like it. No, but they have to do it. So you teach them how to do that properly. You give them exercises to help the baby crawl, help the baby walk, and gentle strengthening exercises. So again, I have a whole host of them that I give depending on what age the child is, I see.
Okay, you are whetting the appetite for me completely with that, because I'm so keen to get involved in that. Dr. Elisabeth Davidson, thank you so much for your time. Is there anything that you'd like to cover just quick that we haven't covered, or something that you'd like to just tie up with?
I don't think so. I think it's going to be really interesting to see. I just noticed, I did a quick sweep of the research yesterday when you asked me, and I noticed there was a whole heap of new papers that have just come out, so I haven't actually read them all yet, and I'm looking forward to do that. I know that they are looking into diet, and there's a couple of really interesting webinars from the elisdanlos.com, which is the American Ehlers-Danlos Association, and they're free. You can go in and find them either on their website or on YouTube. And they have some interesting ones on all the various parts of or aspects of Ehlers-Danlos, but they have a couple on diet and how important that is and how they're looking into that at the moment. There's also a couple of physios in the UK that have been working on some strengthening programs for, not so much for children, more for adults with Ehlers-Danlos or hypermobility. So but we can maybe link them.
Yeah, that sounds like a wonderful resource.
Talk about it.
I'll definitely link it into the body of the video, so people can go and have a check at that. So now I'm just chomping at the bit to be able to get this information, to be able to work with.
Fantastic.
Doc, thank you so much for your time. I'm sure we're going to have you back on, and thank you so much for taking your time to look into the research for us and make yourself available, and obviously speak to your host of experts as well. It really helps us on something like the Pediatric Network. So thank you for your time.
Well, thank you for having me, Mike. It's lovely to speak to you.